If you go to bed the same way every night, same pillow, same side of the mattress, same routine, and you fall asleep flat on your back without thinking twice about it, how sure are you that your sleeping position is actually harmless for your heart, your blood pressure, and your brain? I don't mean harmless because it feels comfortable. I mean harmless in the deeper sense, the physiological sense. The kind of harmless that still holds up when oxygen drops in the middle of the night, when stress hormones surge while you're asleep, and when your blood pressure stops doing what it's supposed to do during rest. Most people never ask that question, and that is exactly why this conversation matters. Because here's the unsettling part. The position you sleep in may not be a small comfort preference at all. For the wrong person, it can become a nightly trigger that quietly worsens snoring, worsens breathing pauses, worsens blood pressure control, and increases strain on the heart and blood vessels over time. I am not saying that lying on your back one night causes a stroke. I'm saying something more realistic, and in some ways more serious. If that position repeatedly collapses your airway night after night, it can create a pattern of stress that many older adults live with for years before anyone connects the dots. And by then, the damage has often been building in silence. Before we begin, please subscribe for clear, practical health guidance that helps you protect your heart, sleep, and future well-being. One of the most overlooked links in everyday health: the connection between sleeping flat on your back, obstructive sleep apnea, high blood pressure, and stroke risk. And I want to do it in a way that is simple, practical, and very clear, because too many people hear the word sleep apnea and mentally file it under snoring, annoyance, or poor sleep. They do not file it under heart strain, resistant blood pressure, irregular heart rhythm, memory decline, falls, or stroke risk. But in many cases, that's exactly where it belongs. So let's start with a story, because one patient's story can explain more than 10 medical definitions ever could. A man I'll call Leonard was 76 years old, a retired accountant, disciplined in the way only some retired accountants are. He took his medication at the same time every morning, kept his numbers written down in a spiral notebook, and showed up to appointments with questions highlighted in blue ink. His doctor had adjusted his blood pressure medicines twice in 1 year because the readings at home were still running higher than expected. Leonard assumed that meant one thing: his body was getting worse. He never once suspected his sleeping position had anything to do with it. Why would he? Nobody had ever asked him how he slept. They asked what he ate. They asked whether he walked. They asked whether he missed doses. But nobody asked what happened after he closed his eyes. His wife finally told him something that changed the whole picture. She said, "You only do it when you roll onto your back." And by it, she meant the snoring that turned into silence. The silence that turned into a choking sound. The choking sound that ended with a jolt, a gasp, and then more snoring. Leonard didn't remember any of it. Not 1 second. What he did remember was waking up tired, dragging through the afternoon, and feeling frustrated that his blood pressure still looked stubborn despite medication. He also remembered the morning headaches, the dry mouth, and the strange way he could fall asleep in his recliner within minutes if the room was quiet. He thought those were age. He thought the snoring was nuisance. He thought the blood pressure problem was separate. It wasn't. That is the mistake I want to help you avoid. Because the issue is not merely sleeping on your back in some abstract lifestyle sense. The real issue is what back sleeping can do in a person whose airway already has a tendency to narrow during sleep. When you lie flat on your back, gravity changes the geometry of your throat, especially if you already have a soft tissue crowding issue, a larger tongue, a narrower airway, extra weight around the neck, chronic nasal congestion, or the normal age-related loss of muscle tone that makes the airway more collapsible at night. In plain English, the tongue and soft tissues can fall backward more easily. That can partially block the airway or completely block it for short periods again and again. And when that happens, your body does not treat it like a small event. Your oxygen level can dip. Carbon dioxide can rise. Your brain senses distress and briefly kicks you toward wakefulness so you can breathe again, even if you never fully remember waking up. Then you drift off and the cycle repeats. This can happen dozens of times an hour in some people. Think about what that means. The very hours that are supposed to be restorative, the hours when your heart rate should settle, your blood pressure should dip, and your blood vessels should get a chance to rest, become hours of interruption, alarm, and internal strain. So the body never truly gets the calm nighttime window it was designed to have. That missing dip in blood pressure at night is not a trivial detail. And this is where many people get blindsided. Healthy sleep is supposed to give your cardiovascular system a break. But repeated breathing interruptions can keep the body in a fight or flight pattern while you're technically asleep. Stress hormones rise, blood vessels tighten, heart rate fluctuates. Blood pressure stays elevated instead of easing down. Over time, that repeated pattern can make blood pressure harder to control, especially in people who are already being treated for hypertension. So someone thinks, I must need another pill, when the fuller truth may be, my body is fighting for air half the night. Those are not the same problem, and they do not have the same solution. Now, I need to be careful and precise here, because I never want to overstate a claim. Not everyone who sleeps on their back has sleep apnea. Not everyone who snores has a dangerous disorder. And not every person with high blood pressure needs to panic about position. But if you snore loudly, if someone notices pauses in your breathing, if you wake choking, if you get morning headaches, if your mouth is dry every morning, if you are exhausted during the day, if your blood pressure stays high despite treatment, or if you've had a stroke, atrial fibrillation, or heart failure, then back sleeping deserves much more attention than most people give it. In that setting, it can be the position that magnifies the problem night after night. Let me explain the stroke part without drama, but with full honesty. Stroke risk is not about one dramatic moment where a position suddenly causes catastrophe out of nowhere. The concern is cumulative burden. Repeated drops in oxygen, repeated surges in blood pressure, repeated sleep disruption, repeated strain on blood vessels, and repeated activation of the body's stress systems can add up over time. That is how risk often works in real life. Quietly, indirectly, consistently. The same person who would never skip a blood pressure pill may be unknowingly spending years in a sleep pattern that pushes in the opposite direction. And because it happens in the dark, in silence, while they are unconscious, it can remain invisible until a spouse notices something frightening or a health event forces the issue into the open. One reason this gets missed so often in older adults is that the symptoms do not always look dramatic. They look ordinary. They look familiar. They look, explainable. You feel tired and blame aging. You wake up twice to urinate and assume that's normal for your age. You lose patience more easily and call it stress. You have trouble focusing and assume your sleep just wasn't great. You wake with a headache and think maybe you're dehydrated. You doze off during a movie and joke that everyone over 70 does that. The danger is not that each symptom is terrifying by itself. The danger is that each symptom is easy to dismiss by itself. And that is exactly how a serious pattern hides in plain sight for years. If you sleep alone, it becomes even easier to miss. A bed partner often sees the part you never see, the sudden silence after snoring, the long pause, the strained inhale, the choking sound, the restless turning, the way the breathing worsens when you roll flat onto your back. If nobody is there to witness that, all you may know is that you wake unrefreshed and foggy. That's why I want you to think beyond the classic picture of a loud snorer. Some people with sleep apnea don't think they sleep badly at all. They just think they are getting older, slowing down, or becoming more dependent on coffee and naps. If that sounds familiar, please do not assume the explanation is harmless just because it has become routine. Here is something especially important for people already taking medication for high blood pressure. If you are on 2 medicines, 3 medicines, sometimes 4, and your numbers are still stubborn, sleep-disordered breathing should be on the list of things that deserves a serious look. Resistant blood pressure is not always about salt, and it is not always about non-compliance, and it is not always because the wrong medicine was chosen. Sometimes the cardiovascular system is being pushed uphill every night by untreated sleep apnea. In those cases, You can keep adding treatment on the daytime side while ignoring the nighttime trigger that keeps feeding the problem. That is like trying to dry a floor while the faucet is still running. You may make progress, but not the kind of progress you hoped for. And there is another layer people rarely discuss: irregular heart rhythm. When oxygen drops and the chest struggles against a blocked airway, the heart is not experiencing peaceful rest. It is experiencing repeated instability. Not necessarily enough for you to feel every episode, but enough to matter over time. That is one reason sleep apnea has such a strong relationship with cardiovascular problems. Many older adults focus on chest pain because chest pain feels like a real heart symptom. But the body often sends quieter messages first: pounding at night, unexplained fatigue, blood pressure that refuses to settle, waking with the sensation that you were suffocating, or feeling strangely unwell every morning before the day has even begun. Those clues are easy to minimize until somebody finally puts the whole picture together. So which sleeping position are we really talking about in this video? For most people with positional sleep apnea, the big concern is sleeping flat on the back, what doctors call the supine position. That is the position most likely to worsen airway collapse in the right person. Side sleeping, especially for people whose apnea becomes dramatically worse on their back, may reduce the severity of the breathing problem. But I want to say this clearly: side sleeping is not a magic cure for everyone. It may help some people a great deal. It may help others only a little. And in more severe cases, position change alone may not be enough. I never want a viewer to hear this and think, great, I'll skip testing and just buy a new pillow. Sometimes the issue is much bigger than that. Still, position can matter enormously. There are people whose breathing disorder is heavily position dependent. In other words, they may be far worse on their back than on their side. That is why a spouse may say, "You only scare me when you roll over." That sentence, simple as it sounds, can be one of the most useful clues in the entire story. If your snoring, choking, or restlessness clearly intensifies when you're flat on your back, do not ignore that pattern. Patterns are where truth lives in medicine. Not one random symptom, not one strange night. Repeated patterns. And a repeated pattern tied to position is exactly the kind of detail that can change what happens next, whether that means testing, positional therapy, CPAP, an oral appliance, or another conversation with your doctor. Let's talk about the people most likely to brush this off. Men often do. Women do too, especially after years of disrupted sleep from caregiving, menopause, pain, or stress. But older adults in general tend to normalize fatigue and poor sleep in a way that younger people sometimes don't. They say, well, everybody my age wakes up tired. Or, of course I nap in the afternoon. Or, I've always snored. And then they move on. The problem is that common and safe are not the same thing. Something can be common and still deserve attention. Loud snoring with gasping high blood pressure that is hard to control, morning headaches, brain fog, dry mouth, irritability, memory slips, and daytime sleepiness may be common, but they are not nothing. I also want to say a word about people who cannot sleep flat at all. If you have reached the point where you regularly need a recliner, or you feel like you cannot breathe comfortably when lying flat in bed, that is not something to quietly adapt to forever, because there may be more going on than simple discomfort. Sometimes people normalize these workarounds and never tell anyone. I just sleep better in the chair. Fine. But why? Is it pain, reflux, congestion, heart failure, severe sleep apnea, something else? The workaround may keep you functioning, but it does not explain the cause. And when the cause involves breathing or circulation, silence can be risky. Your sleeping arrangement should not become the hiding place for an important medical clue. Now let me come back to Leonard, because his story didn't end with sleep on your side and everything was perfect. That is not how real life works. What happened was that he finally got evaluated. He learned that his breathing events were clearly worse on his back, and the bigger revelation was not simply that he snored. It was that his heart and blood pressure had been living downstream from a sleep problem nobody had fully appreciated. Once the problem was identified, his treatment plan stopped being one-dimensional. It was no longer just about pushing pills higher. It became about protecting his sleep quality, his oxygen levels, and the part of the night that had been quietly working against him. That shift in understanding changed the conversation from frustration to strategy. And that, really, is the point of this video. I don't want you to hear one scary idea and go hunting for the worst-case scenario. I want you to recognize when a hidden nighttime factor may be making a daytime health problem harder to control, especially if you are already doing many of the right things. If you take your medicine, if you check your blood pressure, if you try to walk, if you watch the salt, if you still feel tired, still snore, still wake with headaches, still have a dry mouth, still need naps, still get poor readings, then your sleep may be part of the story. And if your sleep problem is worse on your back, then your sleeping position is not a side note. It is an active variable. There are also common habits that can intensify this whole chain reaction. Alcohol in the evening can relax the throat muscles more, making airway collapse easier. Especially in someone who already snores. Certain sedating medicines can do the same thing. Weight gain can narrow the airway further. Nasal congestion can push you toward mouth breathing and noisier, less stable sleep. Even a few years of gradual change can be enough to turn "I snore a little" into "I stop breathing when I'm on my back." And because those changes happen slowly, most people never notice the turning point. They simply arrive at a new normal. And new normals are dangerous when they feel ordinary. Ordinary discomfort is one of the most effective disguises serious health problems ever wear. Let me give you a practical filter. If any of these sound familiar, don't just file them away. Use them. Loud snoring, pauses in breathing noticed by someone else, waking up gasping, morning headaches, dry mouth on waking, needing the bathroom several times a night, daytime sleepiness, trouble concentrating, irritability, falling asleep while watching television, high blood pressure that stays elevated despite treatment. Those are not random, unrelated annoyances. They form a pattern. And when that pattern is paired with back sleeping that clearly makes the breathing worse, the odds go up that you are looking at a real sleep-breathing issue, not just restless sleep or getting older. You do not have to diagnose yourself. You do have to stop dismissing what may already be quite visible. If you're wondering, how would I even know whether my back sleeping is the problem? Start with honesty and observation. Ask the person who sleeps near you. Ask whether the snoring worsens when you're flat on your back. Ask whether there are pauses, silence, choking sounds, or sudden jerks awake, especially in that position. If you sleep alone, consider whether you wake yourself snoring, whether you wake short of breath, or whether your mornings feel consistently worse than they should. Some people even notice that they feel more congested, more headachy, or more exhausted after nights when they remember starting out flat on their back. These are not perfect diagnostic tools, but they are valuable clues. Clues are how good conversations with doctors begin. Now, I know some people hearing this will immediately think, fine, I'll just force myself onto my side. That may help, and in some people it helps quite a bit. But I want you to do it thoughtfully. Sometimes simple positional strategies are used to keep people from rolling onto their back. Some people place a pillow behind them. Some use a wedge. Some use devices designed to discourage back sleeping. Some even use old-fashioned methods that make the position uncomfortable enough to avoid. The idea is simple. Make it less likely that gravity gets the advantage over your airway. But again, if symptoms are significant, do not turn this into a do-it-yourself substitute for evaluation. A better sleeping position can be part of the answer. It should not become an excuse to avoid finding out how serious the problem really is. And please do not make another common mistake, which is assuming that if side sleeping helps a little, the issue must not be important. Sometimes a problem feels modest only because you accidentally built a workaround around it years ago. Like always sleeping propped up, always turning onto one side, always falling asleep in a chair, always avoiding alcohol late, always waking before the deepest part of sleep. The workaround may reduce visible symptoms, but the underlying condition can still exist. That's why people can be surprised when testing shows more than they expected. The test is not there to prove you were imagining things. It is there to measure what your body is actually experiencing when you are unconscious, when you cannot observe yourself, and when daytime guesswork stops being enough. I want to say something to spouses, adult children, and caregivers too, because very often you are the first person to notice that something is wrong. If the person you love snores loudly, stops breathing for brief stretches, jolts awake, or seems much worse when they roll onto their back, please do not assume they already know how serious that may be. Because many truly do not. They may be embarrassed. They may laugh it off. They may insist they are sleeping fine. Meanwhile, they are waking exhausted, living with uncontrolled blood pressure, and never connecting the dots. Your observation may be the thing that finally gets them evaluated. Sometimes the most important medical information in the room is not on a lab report. It is in the sentence, "I've been watching him sleep, and this happens every night." Another reason this matters so much for seniors is the downstream effect on falls, attention, and daily function. Poor sleep is not only about feeling tired. It changes judgment. It changes balance. It changes mood. It changes reaction time. And if you are already dealing with blood pressure medications, nighttime bathroom trips, arthritis, or morning dizziness, a layer of untreated sleep apnea can make everything harder. The person who says, "I'm just not as steady as I used to be," may not realize that fragmented sleep and repeated oxygen dips are part of why mornings feel heavier, slower, and more disorganized. Again, I am not saying sleep position explains everything. I am saying it may be quietly worsening far more than people suspect, especially when back sleeping is feeding the breathing problem. There is also a mental health dimension that people rarely mention in these conversations. When sleep is constantly disrupted, even in micro-awakenings you do not remember, the day feels different. Patience shortens, motivation drops, small tasks feel larger, worry feels heavier. Some people begin to feel like they are losing their sharpness, or their resilience, or some piece of themselves they cannot quite name. They blame stress, age, or personality. And yes, many factors can play into that. But do not underestimate what poor oxygenation and broken sleep can do to mood and clarity over months and years. When breathing is unstable all night, the cost is paid in the daytime, often in subtle currencies that do not immediately look like a sleep disorder. Here is the distinction I want burned into your mind. Comfort is not the same as safety. Some people feel most comfortable on their back because it seems open, supported, and familiar. But for a person with positional airway collapse, that familiar position may be the very thing that increases risk, not in a dramatic movie scene way, but in a slow, repeated, physiological way. The body does not care what feels emotionally familiar. It responds to airflow, oxygen, pressure changes, and stress signals. That is why one person's harmless habit is another person's nightly problem. Your body's anatomy, age, weight, congestion, muscle tone, and medical history all shape the answer. So stop asking only, "What position feels best?" and start asking, "What position lets my body breathe most safely through the night?" If your doctor has never asked about snoring, gasping, daytime sleepiness, or sleeping position, that does not mean those details are unimportant. It may simply mean the appointment had too many competing priorities. And that is exactly why you should bring it up yourself. Tell them if your partner sees breathing pauses. Tell them if it's clearly worse on your back. Tell them if you wake with headaches or a dry mouth. Tell them if your blood pressure has been difficult to control. Tell them if you feel exhausted even after enough hours in bed. Good medical care often depends on good pattern reporting. You do not need to arrive with a diagnosis. You need to arrive with observations. Observations are what turn a vague complaint into a solvable problem. And if you are already using a CPAP machine or another treatment for sleep apnea, this conversation still matters. Some people assume the machine ends the story. But position can still matter for comfort, leak, symptom awareness, and overall sleep quality. Others stop using therapy because it feels inconvenient, then drift back into the same exhaustion and blood pressure frustration as before. If that sounds familiar, please don't quietly abandon treatment and call it a personal failure. There may be an equipment issue, a mask issue, a pressure issue, a dryness issue, or a fit issue that can be improved. The goal is not perfection. The goal is protecting your brain, heart, energy, and long-term function. Sleep treatment is not cosmetic. It is medical. Let me give you a very simple test question. If I asked you right now, what happens to your breathing when you sleep on your back? Would you know the answer? Most people wouldn't, and that alone should make you curious. We monitor blood pressure, we track blood sugar, we check cholesterol, we weigh ourselves, but we rarely ask what our breathing does for 7 or 8 hours every night, even though that breathing may be influencing all the numbers we obsess over during the day. That blind spot is what I want to shrink today, because once you see the link, you can't unsee it. The stubborn blood pressure, the morning headache, the dry mouth, the fatigue, the spouse's concern, the back sleeping pattern, it all begins to fit together in a way that finally makes sense. Drop a comment below and tell me this. Do you usually fall asleep on your back, your side, or in a recliner? I read these comments, and they help me understand what so many of you are dealing with in real life.